Okay, what I've done in this next drawing is I've added more detail to your pressure volume curves, so you start understanding the relevance to clinical practice. One of the really important things about understanding pressure volume curves is that they're very useful models to be able to decide what will happen in certain situations to alterations in preload, afterload, and contractility. What this pressure volume curve is showing you is a normal pressure volume curve over a cardiac cycle. Specifically, I want you to pay attention to the green point here. That green point is your preload point. Preload is one of those values that indicates to you exactly how much volume that is located inside the ventricle prior to contraction taking place. Of course, this applies to the ideal sarcomere length when you're actually looking at the overall value of the preload. Now, one of the things that I want you to understand is that this point in time is also a point in time when you're looking at a PA occlusion pressure waveform, which would be at the C wave. So when you're looking at a PA occlusion waveform, you're really not looking at the whole waveform to indicate to you preload, but you're only looking at a certain point in time, which would be consistent with mitral valve closure point. Now, this preload point is described on this graph, this PV graph, as either the left ventricular end diastolic volume, which would be the ideal to have, but this is actually fairly difficult to monitor for unless you're using TEE and with 3D TEE. Instead, we use the value of left ventricular end diastolic pressure at the C wave using the PA occlusion pressure. So that's really where we're actually coming up with this idea of PA occlusion pressure being tied in with preload. Okay? So this point in time here is a true indication of preload state in the patient. Okay? What I want you to understand here by looking at this picture here is that isovolumetric contraction is where a great majority of the workload is done by the heart during systole, and this can actually be altered by changes in the afterload point. The afterload point is usually determined by when the aortic valve opens. Okay, the maximal work load is to actually open up the valve due to the back pressure that's found inside the aorta, as well as due to reflectance wave and other issues that we'll talk about in the time. Once the afterload point is reached, the ventricle is able to open up the valve, and it begins to eject the volume out of the ventricle, okay, eventually leading to the point of the aortic valve closure, which is here, which would indicate the end of systole. What's funny about this point as well is that this point indicates to you the actual contractility point, okay, for that specific pressure volume curve. But I want you to notice that this blue line here, which denotes a contractility line, is different than a Starling's curve. A lot of times in books they get it mixed up, saying that contractility lines and and Starling's curves are the same, and they're not. They're different. There's correlations between the two in the sense that Starling's curve will be altered by a changing contractility, but it's not that it's the contractility line and Starling's line curve fall on top of each other. They're slightly different. Anywhere along this blue line would be a patient which would have unchanging contractility. So as long as this curve does not shift, this line would not. If that person reaches that line, it would be indicating to you that the patient's contractility is remaining unchanged. The next slide will show you not only the points of significance, but also how these actually points change. Preload only changes in one or two axes. It changes up the preload line, okay, as you increase volume, or you go down the preload line when you decrease volume. In addition to that, you have the aortic valve closure, which is the afterload point. It either goes up in a vertical plane or down, okay, which would be a decreasing afterload. And then the contractility line will shift left and right via these arrow directions. What I want you to do when you're working on your on the workbook that I've asked you, or actually the assignment that I've asked you to work on, the project number 2, is that I want you to change only one of these points at a time until you get into more complex medications, in which case I want you to change them as you think the medications affect multiple points, and as a consequence see the ultimate effect on the pressure volume curve. Always when you do these kind of things, make sure that you put down a normal curve initially so you have a reference point by which you can see the changes that are taking place due to the medications or to the situations that you think you're in. Now, exactly what is preload? And preload is just the sarcomere length just prior to contraction. It basically applies with follows Starling's law that as you increase the sarcomere length or increase the actual preload inside the ventricle, you will tend to increase the actual cardiac output, which is consistent with improving sarcomere distance up to around 2.2 microns. Once you get to that point, then the ventricle or the sarcomere begins to fail. So sarcomere length follows Starling's law as long as you don't reach the point of maximal stretch. So the pressure volume curve very well mimics this study that what we showed you previously by the Japanese, which showed how the sarcomeres change. So preload actually follows the same kind of situation as the sarcomere, just in a more global phenomenon. Now, what we actually have a very difficult time, instead of measuring the actual sarcomere length, is that we begin to apply this Starling's law by looking at the actual total volume inside the ventricle, which we call the left ventricular end diastolic volume. This is actually a fairly hard thing to do, and it actually can be measured now with the new modern 3D echoes, but still they're cost prohibitive at this point, and as a consequence, we don't foresee 5 or 10 years before we have a 3D TEE in our operating rooms. The next best thing that we have available at this time is the use of left ventricular end diastolic pressure, which is fairly much correlated to the PA occlusion pressure. Now, one of the things that I want you to understand, though, that is related to the actual compliance of the ventricle. Okay, so this relationship, as you can see that I'm showing here, is this preload line is not a linear example. You don't see a one-to-one correlation with the change in volume with the same change in pressure. So as a consequence, you have to take in consideration the compliance of the actual ventricle to the actual expected changes in pressure that you would see. When we discuss compliance on ventricles over the next week, this will become a little bit more evident. The preload curve can actually be altered by several different situations. You can have either a decreased ventricular compliance or an increased ventricular compliance that can actually will shift the preload curve up and down. When we talk about later on about valvular dysfunction and with eventual dilation due to chronic like aortic insufficiency or chronic mitral regurgitation, we will note that the ventricle begins to dilate, and the consequence, one of the things that you do see in almost all your drawings of valvular dysfunction is that you have an increase in ventricular compliance, which means that the ventricle is able to accept more volume with very little change in pressure. Okay? Things that will cause a decrease in compliance, which we'll talk about another time, will be ischemia, tamponade, and hypertrophy. As for increasing your ventricular compliance, will be a dilation or decreased wall mass. Remember, the preload curves change in pressure. Changes in pressure without changing volume would be a situation where you would have an increased compliance. Now, this is a nice drawing showing you the normal preload line here in the green, and it shows you two examples of what happens when you change these preload lines. Okay, if you have an increased ventricular compliance for the same expected volume. Okay, so in other words, both these examples show a left ventricular end diastolic volume around 107 cc's inside the ventricle. At the increased ventricular compliance, you would see left ventricular end diastolic pressure of only 7, where normally for that same volume in a normal situation, it would be around 10. If you took that patient and made the heart hypertrophy or develop ischemia or developed things where you have decreased ventricular compliance, you can see a significant rise in this left ventricular end diastolic pressure to as much as 22 or even higher, depending on the situation you're in, just simply by this change in compliance. And you're really not altering the actual sarcomere length. So that's one thing you have to take into consideration. Alterations in preload are an example of what happens when you actually decrease preload. This point here shows that the left ventricular end diastolic volume has dropped. So this is a person who could be hemorrhaging. And what I want you to understand is when you look at these examples is that you don't change more than one parameter. Okay, so when I'm asking you about only decreasing preload, I don't want you to talk about the next step, which is how does the heart respond to this, but rather what's the immediate effect of a drop in preload. What will be evident is that if you don't alter the afterload, is that just simply decreasing preload will reduce your actual stroke volume as long as you're not altering your contractility, which is, again, here you see no change in contractility point, no change in afterload point, but you see an overall decrease in actual effective stroke volume. What you also notice about this is that the volume inside the ventricle and it still remains the same at the end. So your left ventricular end systolic volume is not changing when you drop your preload. What happens in this next situation is what happens when you increase preload. When you see an increase in preload, you see the curve point shifts from left ventricular end diastolic volume from this point up to here. As long as you don't exceed, which in this case is a poor example, if you don't exceed Starling's law where you go into failure, as you increase the preload, if you fix the afterload and you maintain the same contractility, you would see that effectively your stroke volume significantly improves. What you still note, even with an increase in preload under normal conditions, as your left ventricular end systolic volume really does not change because you're still reaching the same contractility line. Now, what is afterload? Afterload is the load that the muscle must do once a contraction begins. It depends on multiple factors. One of the things you have to consider is ventricular intercavitary pressure. It's also dependent on wall thickness. Okay, it also could be due to the actual sarcomere length changes, chamber radius, geometry of the ventricle, vascular load, which includes the cross-sectional area of the vascular bed, the actual elasticity of the vascular bed, viscosity of the blood, and the ventricular load work that's being done. And unfortunately, most of the time afterload is actually fairly difficult to measure. And it's not measured, but rather calculated using a PA occlusion catheter. So one of the things that you have to consider is anytime you see an SVR number, it doesn't necessarily mean that's an accurate predictor of what afterload, because you can see how many different factors make this measurement actually fairly difficult to monitor for. Afterload on the PV curve is a point consistent with aortic valve opening under normal circumstances. So it can actually tell you how healthy the afterload is by looking at your diastolic pressure on your pressure over time curve, which is also correlated to aortic valve opening. What you will see is, let's say we take a situation where the blood pressure all of a sudden drops. Let's say the person's drops their systemic vascular resistance down and they vasodilate in the arterial tree. As a consequence, in this example, I've shown you only a change in a drop in your afterload. I have not changed the preload, and the contractility line is also unchanged. You can see from this point that your effective stroke volume actually improves with decreasing afterload. One of the medications that we use a lot in congestive heart failure patients or patients that are chronically hypertensive is that we drop their afterload. And part of the benefit of doing that is that the ventricle is more able to eject with the same contractility. Okay? The other evidence is that it improves patients in congestive heart failure is that it helps the ventricle empty more thoroughly. So patients that have a decrease in afterload will have a decrease in total left ventricular end systolic volume. So the residual volume left inside the ventricle is actually diminished. As for what happens if the patient increases their afterload, that's on the bad side of it. What you see in that situation is you see an increase here in afterload. Let's say it's a patient that develops significant malignant hypertension, or a patient is developing aortic stenosis. And what you'll see if they maintain the same contractility line, you actually see a drop in effective stroke volume. So their stroke volume is actually decreasing due to this increase in afterload. Now this kind of makes sense because when you're actually doing workload, the greatest amount of workload is during isovolumetric contraction. So when you consume even more workload to open up the aortic valve, then you're basically going to basically decrease your effective work to be able to expel volume out of the ventricle. Eventually, what you do see with the increasing afterload is you see actually a decreased emptying of the ventricle, which leads to an increase in your left ventricular and systolic volume. The next concept is what is contractility, and it's basically the ability of the heart to contract with force. The better the contractility, the greater the stroke volume is evident. You also have to consider looking at how rapid the pressure over time curve, which we'll talk about another time when we talk about cardiac waveforms. That rapidity of the angle will also tell you the degree of contractility. Contractility can be actually assessed very nicely with echocardiography and can be indirectly valued by looking at stroke volume. On the PV curve, the contractility line indicates the contractility. So here's an example of what would happen if you alter the contractility. You can see on this blue line, this is our normal curve. And in our patient here that we're using as an example, we have a patient who has actually decreased their contractility. In other words, they're going to possible failure. As a consequence of that, you'll see that the patient, without changing your preload and changing your afterload, that the patient is unable to eject as much volume out. As a consequence, their stroke volume is decreased due to this decreased contractility. One thing you'll also note is that your left ventricular and systolic volume is considerably increased, which increases the patient's risk of developing more excessive filling and pushing the patient into further failure as a consequence to decreasing contractility. So patients that have decreased contractility are much more at risk for developing failure than almost any other changes that you see on the pressure volume curve. Now, on the other hand, if you increase contractility, such as giving medications like digoxin to a patient or giving some forms of inotropes, you increase their contractility, you will notice that the contractility line is shifted from this blue normal line to now this blue dashed line in this direction. And the effective stroke volume that's coming out of the heart is significantly improved. Okay, this leads to a better effective emptying of the left ventricle, which ends up decreasing your overall left ventricular and systolic volume. Now, heart rate is another thing that we measure and when we're looking at the overall function of the heart, because it's a very important component to cardiac output. Remember in prior equations that cardiac output is equal to heart rate times stroke volume. So you have to make sure that the patient's heart rate is always adequate. You want to make sure that their rhythm is adequate, and you want to make sure that the patient has enough time for adequate cardiac filling. If you spend too much time in excessive heart rate increases, you will note that you will you will not be able to fill the heart properly because you will not give the patient enough diastolic time to effectively do this. Now, please don't take that always that tachycardia is bad. In some situations, tachycardia is the only thing that's keeping the patient alive, especially in patients with low stroke volumes that are being released out of the heart. And low stroke volumes could be due to extremely low contractility that's affecting the patients. Patients with severe ischemia or pericardial tamponade, or patients such as lupus that have severe EF problems down to 5 to 10%, really require the heart rate to be on the higher levels for survival. So don't always try to cause the heart to slow down in certain situations unless you really understand the pathophysiology that's underneath. Under normal conditions, tachycardia tends to improve cardiac emptying to a point, but once you reach a heart rate of around 130 to 140, the heart begins to now be unable to empty properly, and as a consequence starts causing problems. But under normal conditions, tachycardia helps decrease preload under most conditions. As for bradycardia, you get the reverse effect. Okay, you get more time during diastole, so you get improved cardiac filling. But the other downside to it is if you already have a high preload state, you can already push the patient even further into congestive heart failure. So bradycardia in patients with failure symptoms may actually be a significant factor that's causing this failure to take place. So sometimes reversing the bradycardia may be a wise choice. The only downside to it, of course, is when you increase cardiac heart rate, is that you increase cardiac workload. So you may actually be putting the patient at increased risk for ischemia at certain times. So again, looking at overall the pathophysiologic event that's taking place is very important for proper management. Now, what exactly happens with heart rate that you see is that if the patient has significant decrease in heart rate, you'll see that the preload point here jumps up, and as a consequence, you will see an increase in stroke volume at times. But if the patient is beginning to be over the top of the heart failure curve, then you will begin to see a drop off in their contractility line as a consequence, and the person will actually drop their stroke volume and actually push themselves even further up the preload curve, causing worsening failure. As for increasing heart rate, you can see that it actually falls, okay, as long as you stay below the 140 heart rate. Once you get above the 140 heart rate, you will start reversing this effect, and as a consequence you have less filling time, so the ventricle is not able to fill as well, but in certain situations it actually may improve cardiac function, like in patients that are in failure. Now, one of the things that I want you to do is when you look at your project number 2 is that these drug models, the PV curves can be used to predict the action of drugs. What I want you first to do is to place a normal curve first, then place each change at the points of interest that are due to the medication that we're discussing. This will give you an idea of the changes that are taking place to the stroke volume. It will also give you an idea of how well the ventricle is emptying at the end of systole, which would indicate to you by the left ventricular end systolic volume. It also will tell you a certain degree of isovolumetric contraction energy requirements that medication may actually do or may actually be preventing. It also will give you the preload point, which is the left ventricular end diastolic volume. And some of these medications may actually alter the compliance curves of the patient, so it may actually end up altering your left ventricular end diastolic pressure as well. One of the things that I want you to make sure that you interrelate cardiac muscle function, mechanics, and ventricular function. And by increasing ventricular volume, this will lead to an increase in length of individual cardiac cells. The increase in the tension of individual cardiac cells causes an increase in intraventricular pressure. And as the intraventricular volume increases, the greater the force of each cell is needed to produce a given intraventricular pressure. The reason I want you to understand this is that this may actually increase the risk of the development of myocardial ischemia simply because of the increase in cardiac workload. So anytime you start increasing volume, always take into consideration that you are making the heart work harder, and at times may actually cause problems as well. Thank you. I hope this has been helpful in understanding pressure volume curves. We'll see you next time.